Hello, hello, hi, hello, hello, hi,
Can we start?
hello, hello,
Can we
hi.
start our session?
Yes,
Hello.
Yeah.
Can we
Is
start?
now
Can we
audible?
start?
hello, hello,
Can we
hi.
start our
Who is
session?
speaking? Dinesh?
Yes, yes,
Hello.
Yes.
Yeah.
yes, we can start. If
Can we
Is
start?
now
Yeah. Can we
audible?
start?
hello,
Right now we are
hello,
starting
hi.
our
Who is
webinar.
speaking?
Dear
Dinesh?
doctor,
Yes,
welcome to
yes,
Digi
Yes.
Neuro,
Yeah.
a
yes, we can
digital
start.
initiative
If
from Health HNU Therapeutics. Today's webinar Today's webinar is on endoscopic spine surgery, a distensive technique, a lumbar discectomy. Our conducted by Dr. S.M. Rohidas, who is MCH neurosurgeon, Dr. Mohinder Kaushal, and Dr. P.C. Ray. I will introduce Dr. Rohidas. Dr. Rohidas. Dr. Rohidas is a well-known neurosurgeon, and he has started endoscopic spine surgery distensive technique in India in 2002. And he has German company, and he has published many books on distensive techniques. And our second speaker is Dr. Mahinder Kaushal. He is a consultant orthopedic spine, knee, and sports surgeon. He has a 25-year experience of orthoscopic and 18-year experience of spine endoscopic practice. He subscribed minimal invasive spine endoscopic fellowship and propagated by Dr. Destandus. And our third speaker is Dr. P.C. Ray. He is a working director of Orthopedic Care Hospital, Bhubaneswar, and he did his spine fellowship under Dr. Destandus, and he has a lot of publication on his names, and he's expert in doing the spine endoscopic surgery. So we'll start our session. Dr. Rohidas sir will start the session.
okay, good morning, everybody. Am I audible?
Yes. Clear.
Yeah. So now we'll start with this webinar today. This is regarding endoscopic spine surgery, interlaminar approach philosophy, the physics and basics of the distensive technique, and we'll discuss about the various interlaminar approaches, and we'll talk about lumbar pathology, that is the lumbar discectomy. This is little bit about the history. 1973, Cambin mentioned about the posterior approach. Loy mentioned about the foraminal approach in 1991. 2001, but actually Dr. Distandus started this technique in 1993, but he came out of Europe in around 2001-2002 with STORS. This conference at Mumbai, at Lilavati, there was a presentation of the endoscopic spine surgery with posterior approach for the first time. And they used the Distandus technique, but the user was Dr. John Chu, not Dr. Distandus. And he had difficulties in all the three cases. That was the message which went through the Indian spine surgeons that, look, this is not something good. When I started studying this, I thought that the interlaminar approach will be very good for the Indian patients. I studied it and I went to Dr. Distando in 2002. This is one of the system which Dr. John Chu has proposed. It's a smart system. You can see this is a tubular retractor and this is the port for the endoscope. But this never became popular. Similar system by one of our Indian neurosurgeon, Dr. Mazhar Hussain, was proposed in 2005. He used the proctoscope and the channel for the endoscope. But this was something like a fixed system where we can use the instrument from the tubular retractor and the endoscope is giving vision. outside the operative area. Then I went to Bordeaux and Mainz in 2002. I started training in neuroendoscopy and spine endoscopy, but I thought that spine endoscopy will be better at a small place like Kolhapur. This is the neuroendoscopy training at Mainz with Dr. Parnesgi. Dr. Distandau came to India in 2004 first at Indore, and we demonstrated a case in Neurology India conference at Indore, NSI conference. If we talk about the endoscopic spine surgery, like the gharanas in the Indian classical music system, we have various gharanas in the endoscopic thing also, like Ustad Faiz Khan in music, Agra Gharana, the Indore Gharana, the Gwalior Gharana. We can have one that is the microendodiscectomy, MED, by Dr. Foley. He used a fixed tubular retractor. Second is Dr. Distandau. He used the tubular retractor which is mobile. He started this in 1993. This is the mobile tubular retractor. This is the outer tube. This is the inner tube. And the third gharana is the transforaminal approach. They go far laterally into the Cambin's triangle and they target medial to the exciting root, the disc. So these are the major gharanas: Dr. Foley, Dr. Distandau, Dr. Young. These are the Indians who are following those philosophies. Fourth one is Dr. Son from Korea. He is using UBE where there are two ports which are mobile. Now this is the tubular retractor. This is the basics of the endoscopic system. In every endoscopic system, whether it is tubular, fixed tubular, mobile tubular, far lateral, you need a tube to retract the muscle. And this was mentioned by Casper in 1977. This is the tube which he used to retract the muscle and reach the lamina. So in endoscopic spine surgery, what you need? You need an endoscope. You need a tubular retractor to retract muscle with minimal trauma to the muscle to expose the lamina. You need endoscopic instruments. And you need a medium to expose the operative area. These are the four basic things. Now the endoscope from 0 degree to angled scope, it is necessary according to the system what you are using. If the instruments and the endoscope go parallel to each other, it is a physics. You cannot use a 0 degree endoscope, you have to use an angled endoscope. Now this is about the difference between the mobile tubular retractor and the fixed tubular retractor. In mobile tubular retractor, we have Distandau's mobile system. Now we have a Son system also, UBE. We can have a single port, they call this as a pure endoscopic, where they use a tubular retractor, instruments going simultaneously, and movement of those three instruments at the site of the pathology. In tubular retractor, Satnam Singh has modified it. Tubular retractor Distandau, Mohinder Kaushal has modified it. In fixed tubular retractor, we started with Matrix, EasyGo system, and there are many other systems also. With the Matrix system, they were not making their own endoscopes. That's why the endoscopic vision was not good. Now with the EasyGo system, the stars has come into the field and the endoscopic picture quality has become much more better as compared to the Matrix fixed tubes. Now this is the difference between the mobile tubular retractor and the fixed tubular retractor. In mobile, the tubular retractor is mobile. In fixed, it is fixed with the scope holder or the tube holder. In mobile, we have to use a 0 degree endoscope. In fixed, we have to use 20 to 30 degree endoscope because the instruments and the endoscope go parallel to each other. In mobile, we can use routine instrument. In fixed, we have to use longer bayonet angle instruments so that the instrument doesn't intermingle with the hand. The muscle is dissected from the lamina in the mobile. You have to go through the muscle, you have to dilate the muscle and reach the lamina in the fixed tubular retractor. This is the EasyGo system. We have 3 different things. We will talk about this, why we need multiple tubes in the fixed later. This is the operative area in the EasyGo. This is how it is fixed. Now there is another thing, is the pure endoscopic fluid-based endoscopic system. They use very small tubes. They need fluid for creating space to work and for the clear vision. As instruments and the endoscope are parallel to each other, they need angled endoscope. They cannot use a 0-degree endoscope. They need to move the whole system together at the site of the pathology so as to cover the entire area of the pathology. They need instruments which can angle at the tip only. That's why the instruments are very delicate instruments. Breakage and recurrent cost is there. Only the entry point is small. At the site of the pathology, same amount of dissection, in fact more trauma, as continuous use of the cautery and RF is there for the hemostasis, because they have to do the hemostasis, they have to use the water to keep the operative area clean. As the tubular retractor is longer, the maneuverability of the instruments from the site of the pathology to the hands, there is colliding of the hands and along with the water irrigation which is continuously there. They need water irrigation for the clear view of the surgical area, which has to be used under pressure or gravity. And there are issues related to the water under pressure, especially when there is a dural compromise, tear or puncture. The skin incision is smaller, but the amount of the bone resection, flavum resection, discectomy remains the same. So there is no change in the goal which we have to achieve. Trauma at the site of the pathology, the dissection is the same as related to the pathology which we are treating. They need smaller instruments. The recurrent cost of the instrument is one of the issues. Now this is one of the interlaminar approach. This is UBE, unilateral biportal endoscopy. Main philosopher is Dr. Son. This is Dr. Son. They use 2 hands. In one hand it is the endoscope and in other hand it is the instrument. It can be drill, it can be RF or other instruments. So these are the 2 ports. Now there is, in UBE it is the less cost of the instruments, as the scope and the drill used by the arthroscopic surgeon are the same. So there is no cost, extra cost. It's a single hand technique. The learning curve is more steep and damage of the instruments in the learning curve, especially the endoscope, is an important issue. Opposite exciting route visualization is the best, which I believe in this technique. End plate preparation for the fixation cases under visual of the endoscope is one of the best things with this technique. Now when we started about the endoscopic thing, there was always an issue about the 3D vision. The microscope can give you 3D vision, the endoscope cannot give you 3D vision. Now when we are using endoscope, we have to learn how to appreciate the depth with the 2 instruments in the hand. That is one of the learning curve you have to go through. This is one of the slides which we used to present initially about the less trauma to the muscle. But nowadays, all the minimally invasive procedures are maximally invasive at the site of the pathology. So the issue of this muscle trauma is not as grave as what it was thought initially. Now we'll go about the endoscopic instruments of the Stendius technique. This is the outer tube, this is the inner tube, very few instruments. This is the EasyGo instrument, multiple tubes and long instruments if you compare the length of the instruments. This is with the metric system. We have multiple tubes according to the physics of the patient, whether it is thin, obese, the length, the depth of the lamina from the skin. All these depend which tube you want to use. Now, in the fixed tubular retractor, we have multiple tubes, and in the mobile tubular retractor, we have only one tube. Same with the Dr. Son's technique. Now, the basic is the fixed tubular retractor has to touch the lamina or the facet. Hence, the length of the tubular retractor has to be longer for obese patients. Movements of the instrument inside the tubular retractor are dictated geometrically by diameter and length of the tubular retractor. When instruments move inside the fixed tube, this is important. Within the tubular retractor, surgeon has to maneuver instruments in both the hands with an angle A. I will show you that the diagram in next slide. This angle between the instrument changes with the width of the tubular retractor, also with the length of the tubular retractor. You can appreciate here, this is the width of the tubular retractor and this is the length of the tubular retractor. And this is the angle in between the two instruments. If the patient is obese and the tubular retractor is longer, the angle becomes acute. So this figure illustrates the principle that the shorter or wider tube allows surgeon better ability to move the instruments. As the length of the tube increases or the width of the tube decreases, the angle becomes acute and it is difficult to maneuver the instruments. In obese patient, when the surgeon has to use longer tubular retractor of the same width as the shorter one, then the angle between the two instruments is acute and the handling of the instruments become difficult. Hence, there is a tendency to use wider and longer tubular retractor in the fixed tubular retractor system. That is not there in the mobile tubular retractor like distant tube. Also, in the fixed tubular retractor, there was a tendency to use the same system for the fixation for the instrumentation. This is what happens in the mobile system distant tube technique. As the outer and inner tube with the endoscope moves together, the angle between the endoscope and the instrument is 12 degrees, which remains constant. The outer tube is docked over the lamina, which is retracting the muscle, and the inner tube is retracting the skin edges. In obese patient, even if the outer and inner tube is buried inside the skin plane, the instruments approach the target area due to the angle between the endoscope and the working channel, which remains same. That angle doesn't change. So in obese patient, that angle doesn't become acute, or in thin patient, that angle doesn't become wider. You can understand here, this is the outer tube with the inner tube and the angle between the instrument and the endoscope, which is 12 degrees. This is in the obese patient, this is in the thin patient. The instrument is targeted in front of the endoscope. The whole tube can go inside. At the same time, you can still target the instrument in front of the endoscope and the angle remains same. But you can move the whole system at the site of the pathology. Like this, you can move the whole system at the site of the pathology. Now, this distant use technique is the air-based endoscopy. We cannot say it is a air-based because we create artificial space by the outer tube. When we try to compare with the fluid-based, then we call it as a air-based. This is the only system which can be used for all the areas like lumbar discectomy, lumbar canal stenosis, cervical anterior posterior, even the intradural SOL. This is the cheapest system available, and this is the only system which can be used with the 3D endoscope. So the skepticism of the 3D vision is not there with the distant use technique. We can use a 3D endoscope. We use the localizing pin for the lumbar region. There is a separate pin for the cervical region. We use fluoroscopy in the lateral view only. There is no need of separate lateral and epilocalization. There are very less chances of wrong level because of this localization, and this is a non-invasive way of localization. This is the localizing pin. We get the entry point here and we get the direction here. This is how we use the localizing pin. This is the localizing pin at the neural foramen. This is at the disc level. When we localize the disc, it is for the interlaminar approach. When we localize the foramen, it is for the foraminal approach to target the exciting root. So we have to be clear in our mind the anatomy of the traversing root and the exciting root, what we are exactly going to target. This is what happens if we use a metal wire or Steinmann pin to localize. You can have a dural puncture like this. When we use the localizing pin, such complications are not there because it is a non-invasive way of localizing. You can target both the levels together by moving the outer tube straight down. It is L4-5. Angulate it, you can go L5-S1. So if you know the direction, there are less chances that you will go to the wrong level.
The cranial end. This is the L4 lamina.
Now this is the L4 lamina.
Base of the spinous process. This is the lateral end and this is the caudal end. Okay. Now at caudally we are seeing this L5 lamina hole. This is the cranial end of the L5 lamina and this is the caudal end of the L5 lamina. Yes.
Now this is the outer tube, this is the inner tube, this is the channel for the endoscope, this is channel for the suction, which are 4 mm, this is channel for the working instrument. This was the old instrument used in 2002. This is the angle in between the endoscope and the instrument, which remains constant. Very few instruments. We use a knee chest position with special pillows. There is no pressure over the abdomen, so the epidural venous pressure is minimal. They don't trouble you during the surgery. Head is lower than the caudal end. That helps in venous drainage toward the heart. There is intraspinous distraction. It is better for the canal stenosis, but this knee chest position can have a problem in a central huge disc where there is a severe pressure of the dural sac. But we can take as an advantage. You decompress more so that you are able to retract the tissue nicely. This is a 130 kg patient, 120 kg patient. The incision remains same because we are using a single outer tube in thin patient and the obese patient. Incision length doesn't change. We go paramedian by about 1 centimeter. Muscle is cut. The fascia is cut and muscle is separated and retracted laterally. Then we put this outer tube. It should lodge over the lamina. Any soft tissue inside the outer tube is removed. We use these two gauze pieces to retract muscle. Now this outer tube creates an artificial space. We use 0-degree endoscope and this gives you zoom effect in between the outer tube and the inner tube. You can see it's an obese patient, the whole system has gone inside. This is the endoscopic view when we put the endoscope, the outer tube, inner tube inside and have a look at the screen. This is the outer tube, inner tube, endoscope, light cable with the camera. Then we use suction in the left hand. We use the left hand with the suction to stabilize the system. This is the second stabilizing force with the instrument in the right hand. There is no holder which is required to hold the system because this is mobile system. And then we use two hands, just like in open surgery, with an angle of 12 degrees. You can use all routine instruments. You can angulate cranial, caudal, medial and lateral. This was the first workshop which we did with single chip camera in 2006. You can appreciate Dr. Distandu here. And this is the 14 inches Sony TV. This was with the single chip camera. This was the vision at that time with a single chip camera. You cannot appreciate the lamina and other thing, but still we were happy at that time because of the patient's appreciation of less pain in post-operative period. This is nowadays we use 3D endoscope, same technique. The visualization with the camera and endoscope has changed, but the technique has remained the same. This is the 3D endoscope. We are using it since 2017. Now you can appreciate the movement of the outer tube and inner tube. This was in 2004, a single chip camera. Again, this is the localization. This is for the neural foramen. This is for the disc, for the interlaminar approach. Here we have to approach from the foramen. This is a representative case, alpha S1 disc superiorly migrated on the right side. Now this is on the right side. This is cranial, caudal, medial and lateral. Now in an endoscopic view, the up is always midline, down is always lateral. We have to decide about the right and left. If this is right sided, so the right is cranial, this is caudal. So this is the interlaminar window. We have detached the flavum. We have used the cottonite to push the dura anteriorly so as to protect it. This is the traversing root. We have retracted the root, and this is the extruded superiorly migrated disc. We are removing this superiorly migrated extruded disc first. This is the extruded disc. Then we go inside the disc space lateral to the traversing root, go inside and remove the contained part of the disc which is degenerated, and this is the relaxed nerve root, shoulder axilla nerve root going into the foramen, and this is the amount of the disc we have removed. We don't remove the disc aggressively. Now this is a right-sided approach. Now this is left-sided. This is cranial, caudal, medial and lateral. Lateral to the spinous process. We have to expose the lamina and the interlaminar window. You can see this is cranial, caudal, medial and lateral. Now this is the left-sided approach. This is the interlaminar window. We start at the base of the spinous process, go laterally, detach the flavum, push the dura with the cottonite to protect it, go laterally, undercut the facet to decompress the traversing root. This is lamina cutting, and this is the traversing nerve root, retracted medial. We have to undercut medial facet if it is necessary to decompress the traversing root. Now this is cranial, caudal, medial, lateral, and this is the traversing root disc in the axilla. You can with the nice vision of 4 millimeter 0 degree endoscope, you can see the conjoint root also nicely. This is one of the conjoint root. Two roots are coming out of the dural sleeve at the same site. This is for the neural foramen. This is the isthmus. We go laterally. We don't go interlaminar. This is the isthmus. We remove part of the isthmus. And this is the exciting root. This is the lateral edge of the dura. And this is the huge extruded disc. The foraminal discs are quite few in Indian people. In European people, it is something around 8 to 10% they found the foraminal disc. Now this is the decompressed exciting root. Medial to the traversing, the exciting root is the disc. This is one of the representative case. Just let me know whether you are able to view the video nicely. If you are not able to see the video nicely, we'll skip those videos.
No, it's okay.
This is cranial, caudal, medial and lateral. We remove part of the lamina. This is the midline. Now this is with the HD camera. This is the midline. We are detaching the flavum now. It's always better to protect the neural structure with cottonoid. I have used cottonoid to push the dura anteriorly. There are two Kerrison punches in the Distandau system, 145 which we have used for the lamina, and now this is 90° 3 mm Kerrison punch to remove the flavum. We remove the flavum so as to expose the operative area from one lamina to the lower lamina. We are going laterally now. You can appreciate this is an extruding disc here. It is an extruded disc at L45, which is on the right side. This is cranial caudal medial lateral. When the cranial end is at the right hand of the surgeon or the screen, it is right sided. When the cranial end is at the left hand, it is the left sided approach. This is a huge extruded disc. And this is the lateral edge of the dura with the traversing root. You can appreciate the area from where the disc has extruded. Now we have used a cottonoid to retract the root medially. This is the caudal cottonoid. Now you can appreciate this is the traversing root and this is the area of the annular tear. This is the annulotome which we can use to puncture the annulus. We can use a 50 millimeter blade also. And we are removing the disc which is contained disc, which is degenerated disc. We don't do aggressive discectomy. I believe in lumbar region, adequacy of the disc removal and adequacy of the neural nerve root decompression, one surgeon has to learn that in a particular patient, what is adequate, the surgeon has to decide during the surgery. Everything is under vision. There is no blind spot. Then we irrigate the disc cavity so as to remove such loose degenerated disc pieces. With this technique, there is a possibility that you can put the endoscope through the working channel inside the disc space. Now this is the traversing route, retracted, and we can go inside the disc space and have a look at it. This is the remaining part of the normal disc. These are the end plates. So you can be assured that there are no loose pieces inside. And the last step is adequate decompression of the nerve root. Now this is the traversing nerve root. We'll decompress it nicely till it is leaving into the foramen. Now this is the traversing root. Shoulder, axilla is here. This is the axilla and the root going into the foramen. You can appreciate this is shoulder axilla. Shoulder, axilla and the complete nerve root. This is one of the video. We can approach the opposite side also. It's very rare. This is a huge disc we have removed from the opposite side. From ipsilateral side, we have gone to the opposite side. This is the traversing route on the opposite side. A huge disc on the opposite side. Ipsilaterally also we have removed same amount of disc. So this is regarding the distance technique. It's a versatile technique. 3D endoscope can be used, and there is the anatomy is as same as the open technique or microscopic technique. This is about the book which we have written about the distance technique. This is the 3D endoscope by Storz. We are using it since 2017, which gives you 3D appreciation. And the intraoperative training is quite easy with the 3D endoscope and the 3D anatomy. We conduct workshops like this. Person one-to-one teaching is there. And this is about the closure of the dura. My two colleagues, Dr. Mohinder and Dr. PC Day, they will be able to show the complications like dural tear and puncture, how to treat them. This is the intradural tumor which we have removed, and we are using this anasto clips to close the dura. This is the size of the incision with the interlaminar approach. This is the transforaminal approach. So please don't compare the incision in millimeters. What the surgeon does at the site of the pathology is very important. Apart from the technique, what we use. If the pathology is tackled nicely, patient is happy, patient is pain-free. That is what really important. Apart from the different techniques, what we use. Thank you.
Nice elaboration. Dr. Rohidas has covered up beautifully about the Destendu technique, and I think Destendu technique is a gold standard. It has stood the test of time since 1993 when Dr. Destendu started this, and now almost close to thousands. I think Dr. Destendu himself has series of 10,000, and with excellent 90% results. Nowadays, what I want to tell my younger colleagues is, before I get up to my presentation,
ठीक आहे.
when in year 2002, after Dr. Rohidas, I visited Dr. Destendu. So we had only option either to pick up a transharmonic system, which was popularized by Jung that time, and the interlaminar system popularized by our mentor, Dr. Jean Destendu. So after seeing various pros and cons, we found the interlaminar system scores over this transharmonic system in our day-to-day clinical practice and surgical practice. So I think we went to Dr. Destendu. We spent few weeks with him as a short-term fellowship and learned this technique in France and brought this technology to India. I mean, after I think Rohidas, I visited him in November 2002, and since then I think there has been no looking back. And we have over the years we have trained so many doctors, Dr. Rohidas, myself, and Dr. PC Day and Dr. Monu Singh also. We have been conducting regular workshops to propagate these techniques among surgeons. Now, I think today, if we see a scenario, before I get into my presentation, the younger surgeon, whether he's an orthopedic or a neurosurgeon, and he wants to embark on an endoscopic spine journey, he is totally confused. He doesn't know what to do. The market is flooded with the endoscopic spine systems, and he doesn't know. I have seen a guy who has bought a transharmonic system, then he's frustrated, then he goes for interlaminar system, again he is frustrated, then he goes for a UB. So youngsters are confused how to start endoscopic spine practice in their clinical practice. So I think that is not the topic which have been given to me. The topic given to me is tricks to minimize learning curve in endoscopic spine surgery by Destendu technique. Am I audible, Dr. Rohidas? And my presentation is clear?
Yes, sir.
Yeah, clear.
Okay, so
Go ahead.
as a thank you, organizers, for this opportunity. This is a platform nowadays, Corona times, that we have to get connected to each other through these webinars. And I think the future is going to unfold post Corona. Only time is going to tell how far we will be meeting each other in meetings, and when these meetings are going to start again. Let's see. That only time is going to tell. So now I'll just share about the barriers. I mean, what is obstacle to learn spine endoscopy? Skepticism, disbelief, and at times hostility have continuously risen over the concept of endoscopic spinal surgery, especially in the early stage of learning by neurosurgeons and orthopedic spine surgeons unfamiliar with endoscopy. Early in the learning curve, the success rate can be less than with a traditional approach. So these are the points which young surgeon has to keep in mind before he embarks journey on endoscopic spine surgery. And of course, these techniques are difficult to learn than microscopic techniques. Steep or lengthened learning curve is the most daunting reason that prevents many surgeons from embracing endoscopic spine surgery. So, and I think we have to accept that nowadays few teaching hospitals have endoscopic curriculum in their teaching endoscopic spine surgery as part of teaching curriculum. But during our times, it was not there. And even today, most academic training centers do not offer such training. Interested surgeons had to learn the technique after they became established and comfortable with the traditional approaches. And if a surgeon experiences his first complication or surgical failure in the early phase of his learning curve, there is strong disincentive for the surgeon to continue, causing him to revert to old ways or perhaps to even argue against the technique. So this is a common thing. I mean, I have come across surgeons who had burned their hands, who had tried endoscopic techniques. They couldn't do it. They were highly frustrated and they become negative critics. They always say that अंदर में कुछ दिखता नहीं है, you can't see inside, vision is very poor, only you see soft tissues. So I mean, these are the issues which I'll be addressing in my presentation, so that how to address these problems and how to overcome out of these problems. So again, barriers, argument is long and steep learning curve. छोड़ो यार क्यों करेंगे? Loop is good enough, microscope is good enough. So argument again is limited view of the operation field and hand-eye coordination difficulty. I mean, you have to learn hand-eye coordination in these techniques. Depth perception, as Dr. Rohita shared, that in 2D image, the depth perception is a matter of experience. It is a regular practice which you learn depth perception in 2D imaging. And in fact, to address that problem now, endoscopes with 3D also started coming in the market, but very prohibitive cost for these 3D endoscopes. And triangulation. Luckily, this is a system. The Stendo system is a system where there is a triangulation is inbuilt. You don't have to struggle for triangulation. And just for the knowledge of my colleagues, triangulation is the ability of the surgeon to bring instruments in the field of view or in front of the endoscope, which usually we arthroscopic surgeons use this term because we have a different ports for the arthroscope to go in and different port for the endoscopic working instrument. In fact, triangulation is nowadays more important as far as spine is concerned when surgeon is trying to learn UBE, unilateral biportal endoscopy, which is popularized by Dr. Sohn. So we have an inbuilt triangulation in endospine. So there's no chance of instruments going astray. Your instrument is in any case going to go in front of the scope and you will not have that problem. And radiation issues are also there. I have seen with the Stendo system, I think you get least radiation exposure. Nowadays, my younger colleagues must understand that, which most of youngsters they don't understand, that image intensifier is a big monster in your operation theater. And if you don't take protective measures against radiation, I think it is a 15 or 20 years down the line when we pay very, very heavy price. Some of my colleagues have paid the heavy price. So always use image intensifier with proper protection gear. Otherwise, it is a very, very serious health hazard in the theater for a surgeon and the OT staff. So the barriers which I've shared with you, I think that has been the reasons for impacting the growth of the endoscopic spine surgery world over. But now the pendulum has swung. Now the market is flooded with the endoscopic spine systems. And as shared with you, surgeons are more than ever confused which system they should go for and which system they should avoid. And it is a now huge market. The companies are coming out with one and after another system, and more and more workshops are held. And only time is going to tell out. There need to be a white paper now which system one should opt for. So now let's talk about how we can reduce the learning curve. Let's talk about starting point. Your first case in the theater. I think a learning rate is a very, very individualistic. Every surgeon is different skills. Every surgeon is a different rate of learning. So to have a proficiency of 90%, surgeon has to do a couple of cases. And there is a one paper in clinical trials in 2004, statistical evaluation of learning curve effects in surgical trials. So to have a proficiency of 90%, how many cases you should be doing and after how many cases you should be proficient, that I'll be sharing again with you. And now there's another paper, an evaluation of learning curve for a complex surgical technique, the full endoscopic interlaminar approach for lumbar disc herniation. So this was a study where there were 3 groups created of patients, A, B, and C, 10 patients each. In first 10 patients, I think if you see the results, compared with the group A, the operative time in group B was significantly decreased, and the patient in group C had much less operative time. So as you do more and more cases, your operative time also reduces, complications also reduce, and conversion to open procedures also reduces. And as you cross around 30 cases, I think you are quite comfortable with the endoscopic system which you are using in your clinical practice. This is another study again from Chinese Medical Journal. This study was on 50 patients receiving same MED from June 2002 to February 2003, and they concluded that spine surgeons performing MED become proficient after 10 to 20 operations. When their skill becomes fairly sophisticated, patient's improvement rate is the same regardless of surgeon's phase of learning curve. So what I want to share with the colleagues is through these papers that you have to have a minimum 20 to 30 cases which are going to frustrate you. That is a time when either you will leave the endoscopic spine surgery and switch over to some other technique, or you have to have a patience and perseverance to continue with the procedures. Moment you cross 25 to 30 cases, I think the journey becomes very, very comfortable. But having said that, I again want to share that endoscopic spine practice is not every surgeon's cup of tea. Some surgeons are not cut out to work through a narrow confines, through a tubular vision, and through a so that handicap is with the surgeon. Then I always advise they can always switch over to microscope or a loop. At the end of the day, you have to give a result to the patient, whether you have used loop or you have used microscope. So the patient is not going to ask you this if he is recovered from his ailment. So now, just touching the principles, Dr. Rohidas has ably covered the principle, but this is very, very important. Be conversant with the assembly. You have got a new gizmo in your theater, you have spent heavily, and you are very excited. I have listed the patient, and one go I'll be able to do the job. That is not a true. I mean, you will be coding a disaster. So, if you have purchased a endoscopic spine system, the first I'll recommend you is that you try to work on a spine model in your theater or in your OPD chamber, and try it about 50 to 100 times. Try to learn the uses of the instruments, and knowledge of physics and mechanics is very, very important, as Dr. Rohidas has shared. Now, the first and foremost problem, level marking is not a very big deal. Whether you use a non-invasive device as it's there in the Destendu set, or use a spinal needle, because we are routinely doing these kind of things from the day we learn spine surgery. Number one, the first frustration for a surgeon, which I come across, or most of my colleagues share with me, is that they are not able to see anything inside because there's a lot of muscle coming in the mouth already. Now, to overcome this problem, soft tissue retraction by osteotome or Cobb's retractor, I think we all know how to use a Cobb's retractor. So it has to be used subperiosteally, and from a spinal start from a spinal laminin junction and go up to the facet joint to retract the tissue. So it should be a from the bony retraction. That is very, very important. If you just get into the muscle and keep on damaging the muscle, you will end up doing more muscular damage, more bleeding, and at the end of the day, you will not be able to see anything inside. So this is an art of using a Cobb or a Mayo Caesar, or for that matter, osteotome, which comes with the set. So you have to be very, very careful, and it has to be used subperiosteally. If you have performed this step properly, I think you will get a very, when you push in the tube, you will get a very good exposure without soft tissues causing any problem to you. Now, second way to solve the problem of soft tissues coming in the mouth of the tube is the use of two gauzes. As Dr. Rohidas has shared, you can use one gauze cephalate, one gauze with the long thread. In the beginning of your practice, first 50 cases, you must have a long thread. Otherwise, at times, these gauzes get lost in the muscles, and make sure that they slide along the bone. Never try to push gauze in the soft tissue or in the muscle. Otherwise, you will keep on searching and you will not be able to take it out. As you gradually learn the procedure or you become comfortable with the technique and you have crossed about 50 plus cases, then you can use patties also. Like now I'm in my clinical practice, I rarely use gauze or a patchy, but where soft tissue troubles me, I do use a patchy. Then there are other ways also to avoid a soft tissue coming in the mouth of the tube. There is a now standard one retractor comes with the set. So surgeon has got 1, 2, 3 options to overcome the interposition of the soft tissue in the mouth or tube and see bony landmark clearly before proceeding endoscopically. No point you are blinded by a soft tissue or blood is coming and you start cutting the lamina. I think you will be more frustrated, you'll be more upset. Better that having clear-cut bony landmarks as you see during open spine. And then only you proceed with the next step. And, coming, so again,
Except Dr. Mohinder, please, everybody is switch up or mute your mic, please.
Yeah, thank you. So correct use of endospine tube. Again, endospine tube works like a retractor. It takes away the soft tissues retracted. and you have to have the trick how to detect the soft tissues. I am using more time to emphasize on soft tissue detection because this is a one factor, frustrating factor for a youngster, that they leave the procedure by a simple argument that soft tissues comes in the mouth of the tube and we are not able to proceed further. And second is use of endoscopy, as Dr. Rohidas has shared, that some ladies' voice is troubling in between.
Please unmute everybody. Please unmute. Except Dr. Mahindra. Please unmute.
So third is the angulation with endoscope to visualize the hidden areas beyond the endospine tube retractors. So these are the advantages and principles of our endoscope or Destandau technique, and it is a mobile system. I mean, you can rotate it clockwise, anti-clockwise. You can move it separate caudal, as Dr. Rohidas has shared, that you can address comfortably two levels through one skin entry port. And now, as I shared with you, on the left is the present slide, which shows endoscopic view over the patient, and right is a slide which is on a bone model. So you can see you only proceed with the bone work or a laminotomy, endoscopic laminotomy, or before you take the bites of the superior lamina, you have to have a proper endoscopic view of the field of view where you have to perform a surgery. Here you can see at 3 o'clock position in my endoscopic picture, you can see the lamina nicely, and you can see the patchy. I have used a patchy here to retract the soft tissue to minimize the learning curve. So patches are very, very important. Gauzes are very, very important in the beginning of one's endoscopic practice. So once you have good endoscopic view, you should be able to see the superior lamina. You should be able to see the phlegm right in the center, and you should be able to see facet on at 6 o'clock position and midline at 12 o'clock position, right? So once you are able to see these this picture, then you can comfortably proceed with the bone work or taking few bites of a superior lamina. You can use nowadays burr also surgeons are using, or for beginners, I think 3 millimeter Carrison punch or 2 millimeter Carrison punch is an important part of the inventory, and you can use those. So triangulation, as I mentioned earlier, in Destandau technique, I will say that triangulation is inbuilt, so it doesn't frustrate the surgeon. In fact, learning triangulation is the basis of learning endoscopy, whether it is a knee and arthroscopy or a spine endoscopy. And it is, as I stated, it is the ability to bring one or more instruments in operative field of endoscope, which forms the basis of operative endoscopy. And after you have through triangulation, now next thing the surgeon has to learn is depth perception. That is a very, very important. That depth perception comes with the experience. Surgeon has to do 10, 20, 30, 40, 50 cases. Then he will know how he has to use his working instruments. So once triangulation is learned, surgeon learns to orient to 2D wide angle vision and depth perception. Depth perception, once you have mastered, then I think the journey to the endoscopic spine surgery has begun, and you are now ready to take on, add on to your more and more cases you practice. Your operative time also reduces, and I think the results are so good and exciting that you always feel good when your patients are going happy. You also feel happy at the same time. So to minimize learning curve, the surgeon dependent factors I would like to highlight. Experience and technical skill of individual surgeons they vary from individual to individual. As we say, such and such guy is a God gifted surgeon. So we all are God gifted. Only thing is we go to put in more labor, more hard work. We have been able to work hard to secure a MBBS seat. We have been able to work hard. We have worked hard to secure our MS seat and then MCH seats. So I think it is not a big deal that we can't learn spine endoscopy. It is only your mindset. There has to be a proper motivation, and then patience, perseverance, and temperament. I always tell my colleagues, if you want to start spine endoscopy, you should be mentally prepared. In the first case, you should be spending 2.5 to 3 hours. As you do more and more cases, then probably the operation time also reduces. So that mental picture should be there. You can't do like this. I have a next case lined up and I'll do away with this in about half an hour to 1 hour. Then it is not your cup of tea. You have to give adequate time to learn spine endoscopy, and once you learn these techniques, then you will be able to do the job in 30 to 40 minutes time. So during early learning, more time required for the procedure and complications encountered will be greater. That has to be understood. Surgeon should be mentally prepared. It should not upset him, or it should not give an impression that now I'll leave this technique. Every case I am doing and there is a dural injury or I am ending up with the infection. So that should not be a deterring factor. He has to keep patience and carry on. And good idea to set aside longer operating time, as I shared earlier. That is the only way forward to learn these techniques. Now, guidelines, as I stated earlier, that have a spine model in your OPD chamber or in your office, and practice of spine model as much as you can. Then next step is the cadavers, because cadavers are usually not that much in our availability. You can only attend few workshops holding cadavers, this thing, but there are skill labs now. Then short-term fellowships. I mean, this is what is very, very important. You must spend 2 to 3 weeks with a surgeon who is doing these kinds of procedures. Then only you get that confidence and you are able to shorten your learning curve. Then dedication, patience and perseverance is very, very important. Nowadays, I am seeing first a youngster or a surgeon should be clear what exactly he wants to do in his life. I see nowadays a youngster who is attending transforming workshops also. He attends interliner workshops also. He attends UVA workshops also. And he is more than ever confused. What should I do now? So I think the onus lies on most of the senior colleagues that how these guys are to be guided. And most of them are ending up buying 1 system, 2 system, 3 system. At the end of the day, they will be having cheated by companies. They have spent about 20 to 25 lakhs and they are able to do nothing in their clinical practice. So I think now there is a need to discuss this. Sorry. So, and techniques are self-taught and self-learned. No one is going to hold your hand and do it for you. You have to practice these techniques regularly on your spine models, and then only you should be able to master the techniques and you should be able to do them as a treatment method on your patients. And initially, you should be mentally prepared. It is an interlaminar technique. So, interlaminar technique in a sense are more forgiving, that if you're finding difficult proceed comfortably, you can always convert it to open or a microscopic. And those guys who have a previous arthroscopic experience is a added advantages, especially my orthopedic colleagues who are doing open spine surgery and has been doing some routine arthroscopy. So for them, learning is surely easier than those colleagues who have no experience or exposure to arthroscopy or endoscopy. So to conclude, the carry-home message will be visitation. So first, if you want to do a particular procedure, you read literature, you read studies. Now, Destendu has a standing of almost about 20 years plus, and more than 15 to 20,000 cases have been done world over by this system, and it has stood test of the time. New technique systems are coming in now, where they are in the market for last about 2 or 3 years. So study all the studies carefully, and critical analysis is very, very important. So then you plan and visit a center where the technique which you want to learn, you must visit that center. And after visiting that center, try your hands on cadaver. That gives you a depth perception. And finally, try and work on spine models. You should have a spine model in your office or in your OPD chamber, as I stated earlier, in theater, where you must practice whenever you have a free time, and then go and do first surgery in your theater. That will surely minimize your learning curve and minimize your complications, and learning will become comfortable, easy and enjoyable. Thank you very much. So I am done with my presentation. Thank you, team organizing, once again for this opportunity.
So you stop your screen share and take your coffee. By that time, Dr. Nilesh be ready with the questions. I just have a question to Dr. Rohidas. Dr. Rohidas, please unmute. Dr. Rohidas, please unmute. Unmute. Okay. I have a question to Dr. Rohidas. Are you able to listen to me?
Okay.
Yeah. Suppose a young surgeon, very enthusiastic, have 5 years practice, and he is getting 5 to 10 cases of disc every month, and he has the all set of also one, and he is also working well. He want to now learn the endoscopic technique, and he came to you to ask about that what will be the procedure that I will should take up, the transforaminal or this interlaminar, that distensive technique, which will be the best one so that I can purchase and I can proceed. Rohidas, unmute please. Unmute yourself. In your computer,
Yeah.
I think, yeah.
There are two questions which which have come to us.
Be precise and complete in 2 sentences.
No. Because we'll have to answer this question because young surgeons will be interested in knowing that.
Yeah.
How can I start endoscopic surgery in my institute? I have not any endoscopic set. Which endoscopy set is cheap and suitable for beginner? Second
Not
question,
asking about
what
cheap,
are the advantages
not
of
about asking the
endoscopic
cheap. He is
dissection?
asking in toto that which will be the suitable for him to learn and which will be implemented in his practice in India.
Now he has to learn basically what sort of cases are coming to him first. If he is going to operate only 4 or 5 cases in a month, it is not a suitable thing to start this completely separate technique for the endoscopic. What he is doing routinely for 4 or 5 cases or 3 cases in a month is suitable. But the cases are more, then he has to think about he has to go for the training courses of interlaminar approach, the transforaminal approach, learn the basic anatomy, the technique, the instruments, how to use them, and then he has to decide which technique suits to him. I opted for interlaminar because I thought that this is the approach which is useful for all pathologies like disc, canal stenosis, even the intradural tumors, all the regions like cervical, thoracic, and lumbar. So I choose interlaminar. That everybody has to make his own study, make his own institutional study, what he is up to, how much he can invest, how are the patients, and then he has to decide. Okay?
Yeah, I think it's a clear message for you. And what about the transforaminal? If there is an extraforaminal or the far lateral disc?
No, transforaminal is a very good. Each and every technique is very good in its own sense. You have to choose what you want to do. Transforaminal has limitations. So I thought I have to create my brand value as an endoscopic spine surgeon. So what I decided, I need a technique where I can do everything. I can do intradural tumors, I can do anterior cervical, I can do posterior cervical, thoracic, lumbar, canal stenosis. This is everything with one technique. So I am happy with this. If I have to use transforaminal, I have to use a different set or different technique for stenosis and other pathologies. So for me, interlaminar with distensive was the best thing, best technique. So I choose that.
So do you think that this one position, that your positioning of that lady you have shown that 130 kg, do you have any problem to positioning those type of heavy patient?
No.
And
100, yeah, that is the maximum I operated, 130 kg.
You are putting some lateral support to the leg?
I have tied that patient with the bandages.
You can
give lateral supports also.
Yeah.
Can I respond?
Yes, you have a question for you also.
No, one question I want to answer that Rohidas also answered. Now, I want to share with my colleagues.
After this Mohinder's answer, you continue with your presentation and then we'll start discussing. We have questions.
Yeah, I think now, as Rohidas has beautifully answered, transformanic and interlaminar. Now, one system, all solutions or many solutions. Now, couple of our transformanic guys who were, am I audible?
Yes.
Who were using transformanic system. Now they have become wiser of late and they realize that few of the pathologies can't be addressed transformanically. Now they have learned it and now they are doing interlaminar procedures also and they have invested heavily. So in the one go, if you want to save on economy, you learn and master one technique, interlaminar technique, and it addresses all the issues. So this is what I want to tell. First you buy a transformanic system which is very costly. Then you switch over to interlaminar. So message for the younger generation is that going for interlaminar system, master that technique, and it solves your most of the problems. You really don't have to go in for a transforming system, to my mind, as far as surgical practice is concerned.
Okay, thank you very much, Dr. Nilesh. Are you asking some questions? Is there a ready, or I will just go for my presentation?
You go for your presentation, and then we'll.
Yes, my slide is ready. Are you able to see my slides?
Yes.
Yeah.
Okay.
For your presentation, we will take later on.
Okay, so this is a patient of 55 years. Are you able to see the video, Nilesh? Mahinder, are you able to see the video?
Yes, yes.
Okay, so this is the patient of 55 years male having the lot back pain, and for last 25 days when he came to me with the left side radiculopathy up to the knee, and there is no neurological deficit, no blood and bowel involvement. He was able to walk with a pain, little bit of severe pain, but he was able to walk at 10 to 20 steps. All the deep jerks was normal, and then so this was the MRI of that patient. X-ray I have missed. This was the huge extruded disc at L1, L2 level, and extruded and migrated upwards almost one level above. That is almost the whole of the posterior surface of the L1 vertebra is covered and almost extended about D12L1. And this is the huge disc that is just cover the whole of the L1 vertebra posterior surface. And this is the disc here, and this is the disc here, and this is the axial view. There is a annular tear, and this is the report. And now my question is that so this is the 10 things we just have to look up to it, because it's a huge disc. It covers almost the whole of the vertebra of L1 vertebra. It is from the L1, L2 level. And the appropriate patient selection, effective neural decompression constitutes the most important points of the better surgical outcome. Avoidance of the unpleasant complications like the infection, then dural tear, then the nerve injury, and then what will be the time of the surgery? The patient is only 25 days complain. You have to wait for another 1 month of the conservative treatment, or you just wait for 3 months. And then again we'll go for the MRI for 2 months. Then the correct interpretation of the scan and the preoperative detections of the underlying instability. And if there is no instability, we should proceed, or sometimes this exclusion of the non-discogenic sciatica, or determination of the main cause of the clinical pathology, avoidance of the wrong side or the wrong level, and how to do that in endoscopic technique, because you are approaching from the one side. So more detailed procedure does not necessarily mean the more effective procedure. As Dr. Rohidas told, it is a maximum invasive inside, though it is a minimum invasive outside. So that means you have to do this surgery in the proper way, in the adequate way. Otherwise, if it is inadequate, there is nothing that nobody will excuse you. There is no excuse for this endoscopic technique. So this is the system. Now I want to ask Dr. Rohidas here that what to do and what are the precautions that I should take. What are the precautions I should take?
Precautions are, you have to be very careful. Adequate decompression of the dural sac and the nerve root has to be there. Unless you have decompressed it nicely, don't try to retract it. Otherwise, there will be neural injury or dural tear. So you have to be very careful. You have to be as maximum as possible with the endoscope in the decompression first, and then retract it.
So during the surgery, suppose as you have shown here in your surgery, you are putting a neuropathy cranially, and then you are putting that at the lateral aspect of the the nerve root or transverse root, and then you are pushing the nerve root with the dura a little bit medially, creating the space laterally, so that you can see this space properly. Here it is extruded and migrated upward. How can you put the neuropathies cranially?
That is what you have to decompress it nicely so that you are able to retract it medially. Suppose it is a superiorly migrated, don't use a cranial patty. Suppose
Yeah,
it
that's
is
better.
inferiorly migrated, don't use a caudal patty. Okay.
So here we have to
get a disc which
sacrifice.
is superiorly and inferiorly migrated at the same time. It's very rare.
Right.
So if it is a inferiorly migrated, use a cranial patty to retract it. If it is a superiorly migrated, use a caudal patty. Because if the disc is migrated and still you use a cottonoid, it will get migrated up or down. It will not be in your vision. Okay.
So okay, this is that means you want to say that you have to sacrifice little bit of the bone extra in cranially.
Yes.
Yeah, so that the field of vision interlaminar window will be increased or expanded. Then the field of vision will be better. You can retract the neural tissue medially comfortably, and then you can handle the disc, or you can search for the disc, right? So this
that is the problem.
this is the
That is the problem. Your decompression of the neural tissue has to be good. Otherwise, you traumatize the nerve.
Okay.
Yeah, go ahead. I'll unmute now.
So here, yeah, video is visible now. Video is okay. Visible is running. So this is the first bite at usually we are taking at the spinolaminar junction. I think then we are going gradually midline to laterally. And here the patient is 55 years, so there was a little bit of the hypertrophic facet, that lateral aspect that I am removing now. That you have to sacrifice also, and that you must remove that the hypertrophic part of the facet so that you can decompress complete the nerve root here. And this is your traversing nerve root. This is the midline. We are just decompressing little bit of the midline, and then gradually coming from midline to the inferior lamina and to decompress the neural tissue along with the up to the foramen, inferior foramen. So this is up to the foramen almost, or the traversing nerve root is clear. Then this space is in front of you, and then we have to search the extruded part of the disc, which is almost cranially migrated. But before doing that, I was doing that, going to the searching any free fragment in the disc space. I was searching for that because I was just wanted to dissect the soft tissue. Just maybe here it is a anterior aspect of the dura, so that the anterior aspect of the dural tissue is just clear, so that you can see comfortably and retract the neural tissue a little bit medially, and then you can search for the extruded part or real culprit. That's why I went to inside first, did my discectomy, and then I just wanted to search where it is that real culprit, that extruded part of the disc. So in the left side is the cranial. This is your cranial. This is the left approach, caudal and midline lateral. This is your exciting nerve root. I have removed a little bit of extra bone here. The traversing nerve root will be somewhere here, and this is your exciting nerve root. And then I was searching with my hook, where is that culprit. So I got a little bit of hope that I got something now. There is a white glistening structure. I thought, okay, this is a very good thing. I got the real culprit. But in reality, it is a very small one. So I thought, no, this is not the real culprit, something left. So again, I just tried to search and dissect a little more laterally and make my neural tissue a little more free. Now something is visible. Maybe that is the real culprit. So that was the one piece almost. We removed about 6 to 7 centimeter long, and after 15 days, the patient is walking without any lacuna of anything. and that is the beauty of the surgery. So this is the post of MRI. So this is the pre of disc herniation, huge disc, and post of MRI. So there is a complete removal of the disc, and there is a shrinkage of the annular tissue. And this is the post of again. There is a quite glistening structure here in the axial view. I just like to ask Dr. Rohidas, what is this? Unmute. Dr. Rohidas, unmute, please. Dr. Rohidas, unmute, please. Yes. Now, what is this? What is this white glistening structure here?
This is pre-op or post-op?
This is post-op.
This is dural, the CSF collection.
Yes. So, you saw the video, and I don't know that where it is injured. But anyway, the patient is walking, you saw after 15 days, and I have done the MRI. It is not available here. It is about 3 months. They totally vanished that dural injury or something. It heals. I will go to discuss about this, how it heals later on. Now come to the second case. Before going to the second case, I just wanted to say this is the not cutting the tissue, but preservation of tissue, preservation of the what the Mahinder was telling, that preservation of the epidural lubricating tissue reduces the apicular scarring, and also the technology is evolving, indications are expanding and growing nowadays. So what the indications for this surgery when I started in 2007, now within 13 years, I think is expanding like anything. We are not now able to do all the things that cranially migrated, caudally migrated, opposite side, 3-4 level, 3 level, 4 level stenosis, and also the disc of 3 level, 4 level without any lot of exertion. We are able to finish the 4 level within 1.5 hours to 2 hours. And also the foraminal disc, extraforaminal disc, cervical problems also, anterior and posterior, both can be. So these are the, and pain is less, trauma is less, blood is less, blood loss is less, no complete discectomy, only the culprit has to be removed, and no facetectomy, only the hypertrophic part of the facet, no laminectomy, only lamina has to be dealt with this, that the hypertrophic part of the lamina. And during this surgery, surgeon's comfort is very, very important. There will be no tension that we are going to injure the deep structures like neural tissue. There is the obesity. You saw that 130 kg patient Dr. Vida is operating, and also the osteoporosis, multiple level, hard central disc, opposite side disc, and the bilateral discectomy also possible, extruded disc, migrated downward, upwards, foraminal, everything. Complication like the dural tear, neural injury, you saw that this is a very small dural tear with the collection of the CSF also heals without any problem, because of the when you are just removing the tube, the tissue is falls inside, so there will be very less dead space. There will be no dead space, and there is a leakage of the CSF will be minimal, and usually it heals without any pseudo-meningocele or complications. That is the beauty of the surgery and the beauty of the endoscopic technique. No fixation multiple level like this is required. All these things that are already discussed. So what is the beauty of this technique is this: most of the senior surgeons now interested to learn. And most of the young surgeons, they wanted to make it a career for this. They wanted to be an endoscopic spine surgeon. Young surgeons are learning faster. Nobody could escape from this technique nowadays. This is because of this importance of this technique, beauty of the technique, comfort, less complication. Skepticism and the comments are almost still nowadays. High patient acceptance. Cost is less, as Dr. Vidas already mentioned. Mahinder also mentioned the cost of this technique is very, very less in comparison to the other technique. It is hardly less than 4 to 5 lakhs. Nowadays, people demands the miss. Then when you will go, where you will go? People are also asking for the that technique. Now, learning curve already discussed. Now, this is another patient. This is Ruidas for you. This is the another patient, 56 years male, low backache with right severe radiculopathy, was in the April 2016. And he got operated due to the problem of this. The MRI shows this the extruded and migrated disc L4, L5, almost one level below the L4 vertebra. This is L4, I think, yes. So this is L4 vertebra, then is covered almost posterior surface. The whole of the disc is covered completely. This is a right side disc. And then this is the surgery done somewhere else in the outside Orissa. This is a microscopic surgery they have done. I think they have done the total laminectomy. You can see the X-ray here, the laminectomy done, And then this is the situation of the patient after say about 7 months when he presented to me, 7 to 8 months. And this type of pain only 7 days, and this was the condition. The patient was not able to stand without support, and this is the contrast MRI I did, and then I got found that a recurrence of the disc at the same level L4, L5 and extruded and also a little bit migrated downward, not like the previous one. The previous one before surgery, almost the huge one extended up to the one level below, but this is a small one in comparison to the previous one. So this is after surgery. This is contrast MRI, and this is also shows the same level at the same site at the right side. Now, what are the precautions we have to take and how to approach this patient? This is the 7 days of the pain. We should wait for the with the conservative treatment, or we should go straight away go for the surgery. Dr. Vedas.
No, I usually don't believe in the waiting period. If the patient is in severe pain and if he wants to get relief of the pain, I will advise him surgery. He has to request the surgeon that, look, I want to get relief of this pain. That is the first indication. So waiting for 6 weeks, 3 months, I don't believe in that. Second thing, this is a case where open laminectomy is done. Now you have to respect the remaining bone. You cannot go inside the scar. You have to go lateral, search the remaining part of the lamina.
Yeah, that I'm coming. That is the technique I'm coming, Dr. Vedas.
Identify the bone and then go for the extruded part of the disc.
Right. So I'm coming to the technique now. But before that, I just wanted to clarify from you that why you do not want to, because everybody, even the books, even the research people, they are advising that wait for 6 weeks, wait for 3 months, and then only use it.
This is individual. I have pain. I am suffering from pain. I don't go the research paper. I don't go for the protocols in the journals. I want to get relief of pain. If the other person will say that I will wait for 6 months or 2 years, that is his own view. If I have pain, it's a mechanical problem. I want to get relief of the pain. It's the surgical.
Okay, Dr. Mohinder, I want to hear opinion about this. Just unmute. Dr. Mohinder, please.
See, one thing is very sure, what books write, and of course we do follow that those guidelines, and we do follow that most of the time in our clinical practice. But every patient is an individual patient. Now, at times I see a patient with recurrence with same kind of a picture, but patient is reasonably, he has come walking to my OPD. He is able to tolerate pain. I give him a chance of 4 to 6 weeks. But the patient clinical picture which you shared with me, guy is in terrible pain. I mean, visual analog numerical scale must be 9 out of 10. Or guy must not be able to sleep during night. So I'll tell him, itna pain ho raha hai, better you going for a endoscopic discectomy, or you may end up with a nerve root damage also. I am sure this guy must be having some neurology also in addition to severe pain.
Yes.
Pain is one of the
criteria. You are correct.
Unrelenting severe sciatica which is not relieved in about say I'll say 5 to 6 weeks time, and you have a MRI picture lying in front of you which is cause of his pain. So I'll not like to wait for 6 weeks. I'll give him an option. You decide. Let me know. I like to do discectomy as early as possible, but not as an emergency.
So this history is very peculiar of this patient. Actually, about 20 days of this patient presented to me. 20 days before I operated, his wife also having the similar type of problem, but it was a primary case. It was a disc of L5S1 and a huge disc also. I operated and she was just walking after 2 to 3 hours of the surgery and went back. She was happy. So when he got this message after say about 2-3 months of the surgery of him, that is about 8 or 7 months before, after that he came to know in Orissa also some Dr. PC is operating. So he came to me with his wife, and then wife operated better. So when there was a severe pain, overnight he shifted. He's staying about 600 kilometers from this place, from my place. So now he was begging for the surgery. And when I told, okay, just hold on, I have to go for the MRI and the contrast MRI with all the investigation about 24 hours. Tomorrow morning, I am going to operate. Even overnight, in the morning, 8 o'clock, he rang me, sir, operate me today because I am having the problem of the bladder. I am not able to control my bladder. It is just passing the urine in my bed. So that was the situation. Then my senior resident rang me, sir, patient is having some bladder involvement, and we are posted the surgery in the second case. So we have to, I'm just putting that patient in the first case. So this is with the background, I have operated this patient. Now, see, this is the major problem what Dr. Rohidas wanted to tell you. This is the limited visualization due to the adhesion of the scar tissue, restriction handling of the neural structures in the insufficient visual field, so higher risk of the dural tear and nerve injury. So therefore, the wider decompression, each and every book, what I referred, and almost most of the journals that everybody is advising, I think 5 years before or 6 years before, that open surgery is far better for the recurrences. Because of this wide decompression could justify for the less dural damage, you can visualization will be better, which may leads to the compromise of the stability. So fusion surgery may be considered in some cases like this. It is written in a lot of the journals and books, everything. So now thought of the endoscopic technique. Clear differentiation of the neural structure from the scar tissue. Adhesive lysis performed while preserving the stability of the remnant facet joint would lower the risk of the complication and importantly could avoid the unnecessary fusion surgery. Visualization is so good. You can differentiate the tissue, fibrous tissue to the bone, and you can make a cleavage between the fibrous tissue and the bone and go inside. So view was not fixed like microscope. It is a panoramic view. You can mobilize. So that's why it's called a mobile operating tube. You can mobilize in all directions. You can dissect. You can see the interlaminar window because there is no lamina. You have to hit duct the instrument on the facet. And then you have to try to differentiate the tissue between the fibrous tissue and then the bone and try to make a cleavage between the fibrous tissue and the bone and go inside. So deeper dissection along the bony surfaces from the facet to the base of the pedicle could easily be performed. So this is the way we are just doing it. This is the facet here. This is the facet, the medial aspect of the facet. We have to sacrifice a little bit so that cleavage will be better and retract the soft tissue medially. And then you see this is the situation we are going. So nerve root is just protected by the fibrous tissue. We are not disturbing the fibrous tissue here because if you want to disturb the fibrous tissue, definitely you are going to injure the dura or the nerve. So try to sacrifice a little bit of the medial aspect of the bone that is facet here because there is no lamina available here. So you have to sacrifice a little bit of the facet, make a cleavage, go inside and do the discectomy. There was a huge disc. Okay, so this is the patient after surgery, maybe about 2 days when he was ready to go home. So any comment, Dr. Mahinder?
Good job done.
Okay, so this is the dural tear. This is not the same case. This is a different case. I just wanted to show you the dural tear here. Because of this is a very common complication. All the surgeons, spine, orthopedic surgeons, spine surgeons, they are usually face this type of, this is the commonest complication they have to face. If it is a in endoscopic technique, definitely is a very small tear. If it is a small tear, we only put this some surgical and come out. If it is a nerve root herniation like this case, then put a muscle and then on the surgical and come out. Then no need of any suture. You have seen in the Dr. Rohidas presentation, he was doing suturing. Sometimes the people are doing this staples, or sometimes this is staples is available. What is that called? Vascular staples. That can be done. Or if it is a bigger, you can put the dural patch. Nowadays available the dural patch and then put the jelly or something. So this is the way we are handling of this. Another patient is a very clear-cut case. And a small case. After that, I will finish my surgery, my presentation. This is a. So see the patient's pain, severe pain, and patient is having pain for 8 days. He came for the gastro problem to my hospital. He was not interested to walk. Even in spite of we are forcing that please walk for a few steps so that we can take a video. So severe pain, and he is an army person. and he admitted for the gastro problem in our hospital about 8 days before. He was recovering and he was good. Now he developed this type of pain within this maybe hardly 4-5 days during the hospital course. And the pain was so severe, he was not able to stand, even he was begging for this surgery. So this is the axial view. You can see this is a disc of L4, L5 right side. And then this is the marking of this with the localizing device. Now here just I want to ask Dr. Rohidas, is there any type of problem because you are not doing any invasive, non-invasive technique? Any times have you faced the problem of the wrong label or wrong side like this?
If you are able to localize it nicely, if you follow the direction correctly, and if you know the anatomy of the bone after putting your outer tube, what you are going to see, if you knew that, then there are very less chances that you will get a wrong level.
Suppose there is the anatomical orientation of
the first view after putting the outer tube should match the interlaminar window what you see in the AP X-ray of the lumbar spine. If it is not matching, it's a wrong level. Check it again. Initial stages, check the level with the outer tube in place, take the C-arm, recheck it, and then start.
So this is the things I just wanted to tell the viewers that sometimes if any problem, any doubt, don't be hesitate to check again. It takes hardly 2 minutes or 1.5 minutes to check again. So be familiar. You talk to your assistants, the X-ray technicians. They should be well versed that how to do that. So this is the surgery. I'm going. Okay. So how to control the bleeding? Dr. Mohinder, please. How to control the bleeding? Sometime I'm facing a lot of this profuse bleeding. Sometime. Not maybe 3-4 cases, 3-4% cases. There are profuse bleeding. I don't know the cause. Even I was discussing during the surgery. So with the anesthetist, what is the cause of this bleeding? It's hardly 3-4% of the patient I am facing, not always. Dr. Mohinder, please. How to control the bleeding and what is the cause of the bleeding? Okay, Dr. Mohinder is Dr. Rohidas, can you take up this question?
Okay, I am responding.
Okay.
Yeah, I have unmuted myself. So
yes.
This the problem we do face in a few cases. Number one is we have to properly evaluate these patients so that their coagulation profile is okay. But on table at times we see that BP is also quite okay, 100/70 or 110/70. But patient ooze is much more than as routinely we expect.
Yeah, regular, yes.
One problem which I have faced is that osteoporotic bone bleeds more. This is what I have observed, number one.
Yes.
Number two is controlling the bleeding on table now. As the one step you are already demonstrating, you are using patties to control the bleeding. Then
this patient is an army person and he is hardly 35 or 40.
Yeah, so he must have taken a lot of analgesics. At time, patient will
no. He was suffering from that gastro problem for 8 days, and he was admitted in our hospital.
Yeah,
totally, not on the this analgesics.
That's why I want to tell you that if any history of intake of blood thinners, that is also very, very important. And why was he taking any medicine which disturb the coagulation profile? That is, of course, before preoperatively one has to evaluate and assess the patient. Even anesthetist also evaluates that part. But let's talk about the controlling bleeding intraoperatively. That is what your question is, if I am wrong.
Yes, right. Yes. And it is very rare also. Sometimes hardly 2 to 3% patients.
So I use patches the way you are using. I use micro bipolar coagulation. And number three, in my cases, it's a routine protocol. When we give a prophylactic antibiotic, we give Trenexa also preoperatively. I mean, on table, on OT table. And then I use microbipolar coagulation and I use gel foam also, and plus bone wax if there is a bony bleed. So these are 3-4 3-4 what you can say are the measures which we can take when on table when patient is bleeding usually.
So,
One more.
fine, very good. Yes, Rohidas, can you tell me what is the wrong I have done here?
Sometimes there is a excessive bleeding, especially in cervical. There is no way you can cauterize it. You can use flow seal. Flow seal.
Right, okay.
Use flow seal, wait for a minute and start doing surgery again. But that is very good for cervical because we are dealing with cord and the root. Okay.
And you have to keep check of intra-abdominal pressure also. That also at times causes venous wounds.
Sometimes in osteoporotic patients you can have more bleeding. Yeah. Okay.
Yeah, osteoporotic patient have more bleeding, and sometimes the patient is having with this cardiac problem or maybe prophylaxis, some anticoagulants. That is okay, but without there's all this history and all this all these available maybe factors. Sometimes without any cause, without any visible cause, without any cause, the patient having bleeding. I don't know what is the cause. Is there anything related to positioning? But people are telling the positioning of the knee chest position and putting the buttock little bit 1.5 inch above, that reduces the bleeding, that abdomen is free, everything. So why there is a bleeding?
Bleeding will be there. Now I can see your operative field is absolutely dry. Now you are very comfortable. But
now it is, yes.
Either there was some epidural vein injury which was bleeding and you have controlled that by pressure or packing, whatever.
So in between, actually, I use that bipolar. I have not shown here. I use the bipolar to coagulate that. So that was a little bit helps. And also then I have given a petty cranialin and Caudalie, so that also that compresses the veins, epidural veins, and after that sometime it automatically reduces their bleeding. So we have marked that I have given a crisscross incision to the annulus.
Maybe PC.
Yeah.
Dr. Mehtar has mentioned something different. The patient might be taking any Ayurvedic or herbal medicine and we don't know his coagulopathies. That might be one of the cause. We don't know.
This patient is no more bleeding now because we have given the petty cranial and Caudalie. But initially it was a hazy picture and the bleeding was almost cumbersome. So for the beginner, I just wanted to tell you that be patient. And I think this is the only technique. You put the petty, one cranial and Caudalie, the bleeding will stop automatically. And you have the cautery in that coming in the set. So you can, there's a bipolar cautery also, you can utilize that. So this is the irrigation, normal saline irrigation, so that we confirm about there is no residual or any free fragment left out in this space. And then this is your complete your surgery. Okay?
Okay.
Can I ask one question in this?
Yes.
We will go for the questions step by step. Okay?
For the bleeding control, can we use RF cautery in this kind of surgery?
You can use this. You can use. We are using with the RF. You are using this saver blade to cut the bones, and you are using this bipolar cautery that is coming in the set, destined to set. And we are regularly now using the RF and then the saver blade. Saver blade also very good because we have a protection sheath in the back, and that will protect the dura and the nerve tissue. Then you can have this also. Okay.
Can we go for the?
No. I think his question is, can you use RF blade? RF is the same arthrocare which we use in arthroscopy. So in RF, the stendio and
no, we cannot use RF because it needs fluid medical.
Yeah, you have a special endoscopic microbipolar cautery. I think PC probably didn't show that, or in some of the video, if you can show that tip of the microbipolar.
Yeah.
So we'll go to this now for the question answers.
Yes.
Yeah.
That was a wonderful discussion. Right now we proceed for a question answer, and I will take up a basic question. That question from the Dr. Vivek Kankne from Gwalior. He asked, how can I start endoscopic surgery in my institute? I have a not endoscopic set. Which endoscope is cheap and suitable for a beginner?
Yeah, that question we have already discussed with the Dr. Rohidas has given the answer.
Mohinder, can you answer the question in
only for a beginner, which set is?
Yes. Let Dr. Mohinder to answer to that question.
Or repeat your question, please.
A beginner wanted to purchase the instrument and start endoscopic surgery.
PC, let Nilesh repeat the question.
Okay.
Sir, how can I start endoscopic surgery in my institute? I have not any endoscope set, and which set is cheap and suitable for a beginner. So, I'm asking you one more set in market or some companies bringing their own set, just like a dust and dose. They have some limitation of dust and dose. As a beginner, if we use that Indian set or a dummy set, whatever we call that, some Kalelkar also use with dust and do kind of tubular retractor system and like
Correct.
that. So
Yeah.
they have some complication and either young they fed off it. So that is the question this person want to ask.
The complication, you buy any set or system, complication is a fate accompli, and complications you have to face complication. You can't run away from complications. Now responding to this question, which set to buy? Now there is a Destendu system there, and Destendu like other systems are also there in the market. Number two, and we have another interlaminar systems. So the cost starts from 4 to 5 lakh, and they go up to 25 to 30 lakhs. Now it depends on this guy's pocket. If he's sitting in a big corporate hospital, they will be ready to spend 25 lakh rupees, but after 6 months, they will ask, where is the revenue now? Number one, if he has his own individual practice and funds is a constraint, then the best is a Destendu system. Other Destendu-like system are also available in the market. They are being made by 1 or 2 Indian companies. Then there is an Arthrospine system which is innovated by me, but we subscribe to same Destendu pathology or philosophy. So you can choose one of them which is cost effective, and if you learn these techniques, then you go ahead. I mean, with cost effective systems, you can go ahead and start your clinical practice. And if you are then fond of buying a high end system, fine, no problem. You can always go from Honda City to Mercedes and Merc, but I don't think there is any difference.
Let me add to this. The local Kalelkar set or other set, for the initial stages it is good, but they doesn't have the endoscopic bipolar. That is very important. Initial stages, endoscopic bipolar to control the bleeding is very important. Otherwise, there is a feeling that, look, there is too much of bleeding and it is not possible to use the endoscope in that bleeding state. So that is one of the problem with the local sets. So you need a very good endoscopic bipolar in this set. Okay.
I think very rightly Dr. Rohidas pointed out this, because endoscopic bipolar is not part of the standard set. And at times I have seen surgeons calling up, yaar wo bleeding kaise control karna hai, endoscopic. Then I have to tell them you have to buy a endoscopic bipolar as a separate. Source doesn't give you that. And in fact, all the systems sets to Indian sets also, systems also, they don't provide you endoscopic bipolar. So surgeon has to be very clearly told that he has to have a separate system, separate endoscopic bipolar. Stores is quite a costly gadget, but now Indian systems bipolars are available, which can be used in the beginning.
Initially, people used to buy only the outer tube, inner tube, and the kerosene punches. They didn't used to buy the endoscopic bipolar. So I had made mandatory, maybe in 2009-10, that the Destendu set along with endoscopic bipolar has to be sold together.
So that is the good suggestion.
Go to the second question, yeah.
Then my second question is, it is always necessary to keep patient in knee chest position with a normal prone with some flexion at the hip and knees. Is enough using the bolster in OT?
Shall I take this, Mohinder?
I can also.
It is not mandatory to use knee chest position. I am happy with that. You can use it in prone. In those patients who have knee and hip problems, we use it in prone.
So yeah, for the knee replacement patients, we are putting in patient in the prone, and I have did one surgery, I think, in the lateral position also. And Mohinder is regularly doing prone, and I think he is not using nowadays this knee chest.
See, I have tried knee chest position also. I have tried simple prone position without bolsters and on bolsters also. So I didn't find much difference. But surely with the knee chest position which Dr. Rohidas or PC are using, with that the interlaminar space opens up beautifully. I mean, that's what intraoperatively, which doesn't happen when you're using a normal position. But I always, my position is prone position with neutral lordosis. I never use it lordosis. I always make it neutral. Whereas in Rohidas or PCD position, I think you totally reduce you make it anti-lordotic.
Okay, next.
Yeah.
Sir, any extra advantage using 3D endoscope over 2D endoscope?
It is better to have a 3D vision, no? You get a
depth perception is far better.
Orientation of the lamina, and one of the advantages to create a brand value, I think I explain all the surgery to the patients relative, and they are able to understand with the 3D better than the 2D.
Marketing tool, you mean?
Next.
Sir, this is the question from Dr. Shirke from Kolhapur, and he is asking, can it possible do in under regional anesthesia? What is your own or anybody's experience? So any one of you can answer this question one by one.
First I will answer, then we'll go to Mohinder.
Yes.
We tried doing it in spinal and some local. We have done 5 cases in local, but the patient is uncomfortable. In spinal, I think the patient's muscle relaxation is not adequate. So I usually prefer GA. But Mohinder always does it in spinal. Dr. Distendu does it in spinal and GA both. When he does it in spinal, the patient has requested him, Dr. Distendu's place at Bordeaux, the patient has requested that he wants to see surgery during he is being operated. So there is a small screen in front of the patient's eyes, and he is looking at the screen, and the surgeon talks to him, interacts with him, explaining the surgery like this is the root, this is the disc, we have removed the disc, or something like that. Continue with the Mohinder. Mohinder?
Yeah, Mahinder has to, he's talking to, I think, in phone. But I have also some experience. I have done about 6 cases with the spinal surgery when the patient is unfit for the general anesthesia. But there is no problem. You just giving some little sedation, patient was very comfortable, no problem. Even one case, I just like the Dr. Distendu, I put my laptop in front of the patient eyes, and I was just explaining to the patient and in the detail of the steps of the surgery. So no problem. Anyone you can choose.
I think in the beginning, you must use general anesthesia. Once you have become comfortable and proficient with the procedure, maybe after about 100 cases, then you can change over to your comfort, spinal or maybe epidural, regional. And my 90% of procedure nowadays, lumbar canal stenosis or disc is under spinal anesthesia. Only those patients who don't want spinal or they have reservations, they are very much nervous, apprehensive, they are submitted to general anesthesia, but with their consent, number one. And one good thing which I have observed in spinal is that patient is participating in your surgery. He is watching on the procedure. At times, my patients tell me, Doctor Sahab, hum bhi procedure dekhna chahte hain. Although the surgery is being recorded, number one. And I always, at the end of the procedure, I always tell them to do a cuffing, forceful cuffing. That gives you some idea that if there is any hidden fragment, at times it comes out. And when they are doing a cuffing, you can see from where you have moved the disc that there is an impulse pain, and you can see the fragment is popping out from there. So that is another thing which I am now added in my practice, that otherwise it is entirely a call of a surgeon and a patient. We always give a choice to the patient whether he is comfortable with the general spinal anesthesia. I will be talking to you. So we build up his confidence or her confidence. Then they usually accept it कि हाँ डॉक्टर साहब ठीक है, GA का risk नहीं रहेगा. And after 3-4 hours, once the effect of spinal is gone out, they are up and about and walking around.
Okay, next question.
And it also gives you a natural hypotension also. And anesthetist is, I think our anesthetist most of the time relaxing in his duty room when we are, he has given a spinal. And so this is what I am sharing. I must have done now close to 1,000 plus cases under spinal anesthesia.
There is Nilesh.
Any more question, Nilesh?
From Dr. S.K. Gupta, Agra. What is the advantage of endoscopic discectomy or microdiscectomy? Mohinder.
Which microdiscectomy he is talking about, whether open micro or with tubes?
That he has not mentioned, but you can just answer thinking that it is a microscopic discectomy with
microendoscopic. That is different, no, but he is asking about microscopic.
Okay, I'll respond to both the questions. If it is an open microscopic, I think we have a literature to support that there is a denervation of the muscles and adjacent segment disease is a problem as far as open microscopy is concerned. Now I come to tube microscopic. I think tube, the so-called matrix system, I think that doesn't make much of a difference. It is a call of a surgeon. Through a tube, if you're comfortable with a microscope, you go ahead. But endoscopy has certain advantages over microscope. That is from surgeon angle, not from a patient angle. I hope that answers my question.
Okay, in when you take into consideration only discectomy, so there is no difference. But if you want to do a discectomy along with canal decompression, the endoscopic has a added advantage to go on the opposite side easily. Mobilization is easily of the outer tube. That is the advantage over the microscopic discectomy.
So extruded and migrated downwards, upwards like this.
The mobilization is quite good.
Yes.
Dr. Vijay from Jaipur, how to cut the capsule to reach the disc?
That you saw in the video. That's you can cut the your operating instruments that trephine, that is a round trephine you have cut. You can put your the 10 retractor. You can put the 11 number blade. Whichever method is okay, no problem. Sometimes it is a hard disc, then it is the problem. If it is soft disc, no problem. If it is a hard disc, then you may use that Kerrison punch, 45-degree Kerrison punch sometime to cut that hard portion of the disc. Then go inside.
Dr. Salami from Nigeria, how to deal with fogging of the scope and blood flash? How to deal with fogging of the scope and blood splashing over the endoscope?
Yeah, I think for that, shall I respond?
Yeah.
You have to take out the scope. It is known as the red dot phenomena. In arthroscopic practice, we call it as a red dot phenomena. When suddenly in joint we use a fluid. Here we are not using a fluid. So what we do is we remove the scope, we clean the tip with the help of a saline or a betadine solution, and again start doing the procedure after cleaning the scope. You get a better visibility. And of late, this was the one problem which I was also facing with the system, the Stendio system. So that's why I innovated a arthrospine system where when I have done, I am close to dura, I have removed phlebum, or maybe I am about to remove the disc, I switch over to a saline medium. I mean, that is a dual system which I have probably designed or
that is unstable. Maybe the time has gone
to address this problem. So I hope this answers my question.
Sir, Dr. Salami from Nigeria again asking, can arthroscopic shaver can be used for a muscle removal in the initial approach?
No. Don't use shaver for muscle removal. Take other measures to retract the muscle. Never remove the muscle. The whole exercise is to preserve the healthy muscle tissue. So we can
shaver bar for the bone.
But don't use a shaver for removing the muscle. You can use an arthroscopic shaver to remove the disc. You can put it inside the intervertebral disc space to remove the disc, but never use
shoulder shaver bar. We are using to remove the bone. Even the opposite side bone, that the lamina and then the spinous process, undercutting of the spinous process, undercutting of the lamina, and removing the hypertrophic part of the facet, that bone.
Let's not confuse shaver with a burr. Burr is different, shaver is different. The role is very, very different. Burr we use for a bone work. Yes, you can use an arthroscopic burr for a bone work in spine endoscopy.
So arthroscopic bar and shaver bar is same, yeah. It is used from the shaver. The shaver machine has the two sets. You can use for the soft tissue, you can for the bone. That bone is for the bar, and that is usually you are using for the shoulder.
He's asking.
There is a question from Dr. Vijay from Jaipur. What to do if dural tear occurs? I'll answer first, and then we'll go to other two speakers. In the initial stages, if there is a dural tear, it is a dural tear, major dural tear. So don't have ego, convert it to open and close it. Afterwards, if it is a dural puncture, you can just put a muscle piece inside. You can add fibrin glue over that. You can add tissue dura patch and close it. If it is a very wide, in cases of intradural tumors, we use anasto clips. At the end of this session, I'll show you a video how to close or how to put the muscle piece inside the dural puncture. Mohinder.
Yes.
Dural
you want to add anything in this?
No, I think same. I have been using fat graft, especially when the dural tear is major dural tear or more than 5 millimeter. You can make out here this is a major dural tear. Small tears I don't bother. I do a tight muscle and facial closure and subcuticle skin. That's it. But I have been using routinely whenever there is a dural injury, a fat graft I use it. I put in through the rent, and through a ball valve mechanism it works, and that's it. Even nowadays, other things are available. There is a dura.
I think I have shown that video and I have used that muscle page that what Dr. Mohinder is telling also the same. Mohinder is also telling the same thing that you can use the muscle page or fat. But I am telling my experience of the learning phase that initial of my 20 cases, I think I faced about 4 cases of the dural tear. 3 cases I used that only there was a small tear, there was no muscle, the neural tissue herniation or nerve herniation. So I did the muscle page and small surgicel and then came out. That was okay. But one case that was a little bit cranially migrated my neuropathy. I could not find that I was trying to catch that neuropathy and then use that proof and then the nerve hook. And with that, I torn my dura. That was a bigger injury, and that I asked my neurosurgery colleague who was operating just my side of the operation theater. So he came and he opened a little bit more, and then we did some stitches. Okay.
Nilesh, there is one question which I have got from here, that the pathology can be addressed with interlaminar system being mobile.
That question I'm asking.
Yeah, can you repeat that question?
Yes, sir. Sir, previously you told all pathologies can be addressed with interlaminar system.
There are a lot of interference, I think, that internet.
Where to dock the tube for a foraminal or extraforaminal disc herniation or stenosis? If you have any video, can be.
Yeah, I will show you with this sharing of the screen. Okay. Now you see, when we want to
extraforaminal approach, that
1 minute.
Dr. Mohinder, I just wanted to, by this time, Dr. Rohidas be ready with his video or his presentation about the extraforaminal.
But I'll just see
extraforaminal approach. I just wanted to ask one question to Dr. Mohinder. Is there any nerve root injury you have faced in your practice? And if so, then how you manage with that? And what are the precautions that you want to advise for the young and the beginners? Mohinder, please. Hello?
Unmute.
Mohinder, unmute.
Yeah.
Mohinder, yeah.
So, I mean, you are talking in general the nerve root injury.
Yeah, during your practice, your experience about the nerve root injury, your experience.
I think nerve
how many cases you have faced and how? Yeah.
Nerve root injury is a serious complication. I think surgeons should pray that it doesn't happen. Dural injury is fine. That's okay. That's not a big deal. But if a nerve root injury has occurred, the patient will have disability subsequently post-op. And at times, a patient who was neurologically intact and subsequently if he develops a weakness in the leg or he develops a foot drop, probably it is very difficult for a surgeon to convince him that why it has happened. But I think there should be a very, very open discussion between a surgeon and a patient that gradually, because there is a double dermatable supply at times, there is an overlapping of the nerve roots. So if 6 months to 8 months at times you see that the neural recovery has occurred, it may not have occurred fully, but patient is able to manage. That is number one. Number two is the patient should be counseled that it may recover further, but the plateau reaches by end of, I think, 9 months to or up to 2 years. After 2 years, there's no neural recovery, number one. Number two is if a patient is left with the foot drop and there's no recovery and patient has a disability. In one of my patients who had foot drop, we did it for a tendon transfer. So with tendon transfer, patient's foot becomes 90-degree plantigrade. Beyond that, he or she is not able to dorsiflex it, but disability is reduced. So this is how one has to go ahead. If there is a permanent disability, then some secondary procedures need to be done. But it is a very, 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 very serious setback for a surgeon when a nerve root is damaged completely intervertebrally.
Now,
okay. Vidas, are you ready?
I am sharing my screen. This is the isthmus. For the foraminal disc, we have to target this isthmus. not the interlaminar area. The incision is little bit 5 millimeters cranial as compared to the routine interlaminar area incision. It is same from the midline. It is something around 1 centimeter from the midline, but it is cranial. We are seeing bone here, no ligamentum flammum window. And then we start cutting the isthmus, and then we will be able to see the exciting route, not the traversing route. Okay? We'll go to the...
Yes, I think very clear.
I'll stop sharing the screen and we'll go to the next question.
Yeah.
Nilesh.
Next question, Nilesh.
Next question, just a minute. Sir, this next question comes from the Dr. Sandeep Saraf from Visakhapatnam. How to do a metal interbody fusion in a closed working tube using the Destendu system compared to the MK system, which has an open working channel also?
Mohinder, this is for you.
I think the Destendu endoscopic spine system is designed for discectomy and canal decompression. Now, arthrospine system with MIS fusion is designed in addition to, there is extended indication even you can go in for endoscopic MIS fusion. Now, with arthrospine tube, you are only able to do a intradiscal work. You do a thorough discectomy, number one. Number two is you clear all the tissue from intervertebral space, and then we change over to another hemi arthrospine device you can call. With that, under endoscopic vision, you put in the graft, you put in the cage, and you try to put screws percutaneous manner. This is very important to understand. Endoscopically, you are able to do a intradiscal work. That means you are able to put in the graft, you are able to put in the cage. Once you have done that, then in a percutaneous fashion, you stabilize the spine. And I hope this answers my question.
Yes, sir.
Okay, next question.
This is next question from the Sandeep Saraf, Visakhapatnam. He is asking, is the Strauss system working channel port compatible with any other company 4 mm 0 degree scope?
Yes, any scope you can use it.
Yeah.
It is a universal scope.
It is a universal, yes.
Yeah, this scope can be used in sinoscopy, arthroscopy.
No, other company like this is Starch company scope can be fitted to that the adapter. But if you use the Smith and Nephew or some other company, their telescope, it will not fit. But you can use the same 0 degree telescope for the neuroendoscopy or the ENT surgeons and all other surgeons they are using also. So anytime when I faced a problem, then immediately I take the help of the ENT surgeons scope. But other companies scope is that fitting system, that locking system is different. It is not full fit.
Yeah, I think.
Any other question, Nilesh?
Yeah, the Destendu system.
One minute, Nilesh. Mukul has
Yes,
asked
sir.
on the chat about should we attempt removal or in the hard disc, should we attempt removal of the disc or just decompress posteriorly?
Which a hard disk impinging sufficiently, then you have to remove it. Otherwise, you don't touch the hard disk if it is not impinging. Only this hard disk is not to remove. Most of the time, you just leave it and come out. But if it is sufficient enough and it is extruded and then hard disk become hard, or sometimes this bulging the annulus and they become hard and it is sufficiently impinging, then you have to remove.
Dr. Rohidas, your take.
In a hard disk, suppose it's a fixed disk, there is no movement, just decompress posteriorly. But sometimes we find that the annulus is hardened, somewhat calcified, then we open it with the drill, go inside the disc space and decompress it. Here,
surgeon has to decide on table what kind of situation is there, and he can.
Sometimes in stenosis cases.
Another question Mukul has asked: how to decompress adequately in listhesis?
In listhesis?
Yeah. Dr. Rohidas.
Listhesis, it is the compression of the exciting and traversing route. You have to do a good interlaminar job, go cranially, remove the part of the ligamentum flammum which is forming the superior foramen ligament. in the exciting foramen or in the neural foramen and decompress it nicely. That is sufficient. But you have to do it bilaterally.
Disc removal, even the removal of the disc, most of the time you should avoid because it may add to the listhesis again.
That is what I added in cases of in UBE technique. The opposite exciting route is nicely seen and nicely decompressed. That is one of the advantages I saw in UBE technique. Nilesh,
Yes,
any questions left?
Disc, so no need to disc removal.
Nilesh, any question left?
Yes, sir. Dr. Praful from Belgaum is asking if dural tear occurs in initial part of surgery, then CSF leak continues throughout the procedure, even with the patching. Then this is disturbing to the process with the continuous CSF leak. Then how to approach or how to manage with this?
Now, in distendous technique, there is no continuous irrigation. If there is a dural tear, you put a gauze, small cotton wide over that and finish your work. But if it is a wide dural tear in the initial stages, don't have ego, convert it to open, close it nicely, rather than damaging the dura and the nerve roots. Don't have ego, convert it to open and do it open technique. Any other question?
Sir, as a beginner like me, some of the and my colleague also they are asking. So, which level of surgery means which level of lumbar surgery, this surgery to start with, in L4, L5 or L5S1 like that?
We will ask separate. We will reply this question separately. But I believe it is a L4-5 left-sided, nice extruded disc. So when you decompress the bone and the flavum, the disc is in front of you. These are the cases. L5S1 sometimes with the angulation becomes difficult in the initial stages. So L4-5 left side. Mohinder?
Yeah, I agree with you.
PC?
Yeah, I will say
PCs, I think the net signal is very, very poor.
PC, just raise your hand if you are.
For the dural tear, I just wanted to tell something about the dural tear in the initial phase. The CSF leakage is continuous and it is disturbing to the surgeon. Nothing to be worried, just put a petty and just wait for some time. You may put a Surgicel also and carry on your work. Most of the time, I think 99.9% you will just come out with that. And after the finish of the surgery, you think about put a muscle patch or fat pad and then put the Surgicel or sometime the neural tissue, that available market in the market, that is dural patch with the glue or something. Most of the time you will come out like that.
Nilesh, anything else?
Yes, sir. Sir, most of the questions are finished.
I will answer this one of the question. Any extra advantage using 3D endoscope? There is definitely extra advantage using 3D endoscope because you get a depth appreciation very good, illumination is very good, and to ride a Mercedes is always better riding a Maruti 800. Is that correct, Mohinder?
Yes, sir, that is always but
nice.
Expensive.
Nowadays I'm finding
good example, very good example.
To operate with 2D. I am very well versed with the 3D vision, so it becomes difficult when I go outside.
You see, if you are used to 2D vision, I mean that compensates for 3D vision with experience like me and PC. They are used to now 2D. So I don't think we have to go switch over to 3D.
No, if you want to compare between the Innova and then 3D, the Mercedes.
But youngsters, if they have a 1 crore plus in their bank balance, they can switch over to 3D Dr. Mohinder style. The learning may be little easy. But I think
it's not a question of learning. If you change to 3D, then you will not go back to 2D again.
But I want to go back from Mercedes to Maruti.
That's okay. Nilesh, sir, any other question?
And one more. That is from me, sir. Do you always use Depo-Metrol after the surgery for inflamed nerve root?
I use methylprednisolone.
Same
almost. The nerve root is edematous in cases of canal stenosis, in cases of huge disc. If you see that the nerve root is edematous, I put a gel foam there, and over that I put methylprednisolone. That helps a lot. But I usually use buprenorphine over the gel foam. That gives the patient epidural analgesia, and the post-op pain is very less.
Nilesh, I just want to tell you something about this using of the Depomedrol or Salmeterol. That is, to be honest, I never use in my 13 years of the practice use this. For last 2 months, I was just trying to do that. One day I operated 8 cases, and I think all 8 cases I used that Salmeterol and Depomedrol, whatever that was available in the OT. And it was 40 to 80 milligram. Sometime it is 2 level, then 80 milligram, and 1 level it is 40 milligram. I saw there is some improvement, maybe less pain or something, nothing else.
Yeah, steroid takes care of the inflammatory component. Mechanical pressure once gone, so patient, once the inflammation is taken care of, the patient feels much better. The pain relief is surely better if you inject steroid. But per se, I am very selective using. I don't use steroid in every case.
Yeah, I am also not using till now. For only that few cases I tried. That's all. Okay. No more question. Then we will leave the meeting now. Should we conclude?
Yes, sir.
So Rohidas want to show something?
Hello, can we go for a closing remark, sir?
1 minute. This is a video of a dural tear. You are able to see the screen?
Yes, yes. Go ahead.
Yes, sir.
No. You are able to see the screen.
Yes, screen is visible, clear. You
This
can
is
go
a
ahead.
dural tear.
You just do it slideshow.
No, this is a video.
No, sir, we are seeing.
Okay, start the slideshow, no?
Now you are able to see?
No.
We are able to see you.
No. You
1
have to
minute. Let's. Yeah. Now I'll be able to share. Okay.
Yes. Visible.
This is a dural tear. Huge dural tear. I'm using a muscle piece. You have to use a nerve hook, or this is a spinal needle. Spinal needle is always better than the nerve hook.
Because it will not slip. The spinal needle which
otherwise what happens, you have pushed the muscle inside, and with the spinal hook it comes out immediately. Okay, and this is the muscle piece. And then we put this dural substitute over that. This is the dural substitute. And then over this we have put this fibrin glue. This is complete sealing of the dural tear. Okay?
Nice. Good.
Back to Nilesh now.
Yes, Nilesh. Please conclude.
Sir, I'm on a closing remark. On the behalf of Health HNU, I wish to thank Dr. S.M. Rohidas sir, Dr. Mohinder sir, and Dr. P.C. Ray for their wonderful discussion and demonstration of a technique. I'm sure you must have found it interesting. We wish to thank all of the doctors who took their valuable time to join this webinar. We wish to inform you that the second part of this webinar will be on a endoscopic spine surgery distensive technique for endoscopic lumbar canal decompression. That is the next topic. We will convey the timing. It will be held on the. Please join us. And signing off of the behalf of DG Neuro, a digital new initiative by Health HNU. We thank to everybody.
Thank you.
Thanks, sir.
Thank you.
Okay, bye
Thanks,
bye.
sir.
See you. Thank you, everybody. Thank you, Nilesh.
Thank you, everybody. Thanks, sir. We can conclude.
Thank you.
Okay, thank you, sir.
Thank you.